So thank you so much. I'm Ann Macaulay. I'm a professor of family medicine at Mcgill University. For many, many years I was a family physician working in the Mohawk community of Kahnawake, just 20 minutes outside Montreal.
And can you tell me about that project? It was a diabetes research?
Yes, absolutely. So I started working in Kahnawake in 1970. And the first 10 years was working in partnership with the community, helping them to bring community control of health services to the community. So like all Aboriginal communities in Canada, health services were run by, until then, health services were run by the federal government, and it was their wish to take over control of health and dental services and nursing service in a community of 8,500 people. And then the second 10 years I was there, I started to, my first research was in fact in breastfeeding, because I was really interested to discover from patients why some mothers chose to breastfeed, why some mothers chose to bottle feed, and then to learn from all of the results what I could do to improve prenatal teaching, and with the goal of improving breastfeeding rates. And then, along with a younger Mohawk colleague, so he was Mohawk from the community, one of the first Aboriginal physicians in the country, someone who died at a very young age, very, very sad. He and I felt that we were seeing a lot of people with a diagnosis of type 2 diabetes in the community. So this was in the early 80s. There were no national figures for prevalence of type 2 diabetes in Aboriginal people in Canada. There were some early studies in the US showing high rates. And so, you know, it would make sense if there were high rates in the States, there would be high rates in Canada. So we undertook a chart review in the hospital. We knew that most of the community used the hospital. And we showed a prevalence rate of type 2 diabetes in Kahnawake twice the national average, so twice the Canadian national average. So we were seeing a lot of people with type 2 diabetes. And then we thought, well, not only high numbers of people with type 2, but high numbers of people with type 2 with complications. And again, we did a chart review, and again, we showed high rates of complications. So the agreement that we had with this community-run, community-controlled hospital in the community was that we would share all our results. And so we went round the community organizations. We picked 12 of the major organizations with the results. And we ended the presentations by suggesting that if people were able to eat in a healthy way and be more physically active and to walk more, that hopefully these high rates of type 2 diabetes would be lessened in the future. And about 6 months, so that was 1987, about 6 months after that, some of the elders in the community came to us and said, okay, we want you to do something. We want you to do something to prevent our children, our grandchildren carrying this burden of disease. And we want you to set something up, and we want you to focus on the young children. So that was how the Kahnawake Schools Diabetes Prevention Project came to be, was at the request of the elders. Mm-hmm. And when we set up the project, we being people in the schools and health professionals in the hospital, developed a health curriculum for elementary school children, which also talked about diabetes, because that curriculum didn't exist anywhere else. And so we developed the curriculum, we trained the elementary school teachers, and by the second year they were delivering the curriculum themselves. And so focusing in the elementary schools and then running these supportive projects right through the community so that parents and grandparents, extended family, knew what we were teaching the children, right, and offering them opportunities to be physically active, to eat well, and, you know, to take good habits home, role model and support the children.
Right.
So this is a project that started actually in 1994 and still running today. And I think the important thing to say is that we set this up as a participatory research project.
Right.
So this is researchers working in partnership with who's affected by the issue under study. So in this case, the Community Advisory Board was made up of parents and grandparents and representatives of the organizations in the community, with the goal of people bringing information from their organizations to the project and taking information from the project back out to the organizations. And I'm quite convinced that it's the energy of the community that's kept this project alive. I know it's the energy of the community that's kept this project alive.
Are you still involved in it?
Yes, I'm still involved. So I was principal investigator from 94 to 2006, and then stepped down to become co-investigator.
I see. And the project continues?
So the project continues. Last year it was awarded the CIHR Partnership Award for the country, based on the strength of the partnership, the code of research ethics that had been developed by everybody, defining the roles of everybody in the partnership, and actually used as a baseline document for CIHR to develop the CIHR guidelines for diabetes. The CIHR guidelines for research involving Aboriginal peoples.
Right.
Yeah.
And you were very involved in that document.
So very involved with that document as well. So that's been some of my work over the years. Is writing about participatory research, is writing about the principles of participatory research, and writing about how you put these principles into practice, and then developing these codes of research ethics that not only look at protection of the individual, but what about protection of the community? Does the community want to be named in the publications? How do they want the history to be documented? What's the context that they should be adding to the research results to make better sense of results, whatever they may be? All of these issues, which today are becoming accepted, but when we wrote that original code back in, I guess the big 90s was new, was quite new.
So when you say they're being accepted, how so?
Because today the new Tri-Council research guidelines include many of these core principles now of respect of community in addition to respect of individuals.
Okay, so they're used among not only with Aboriginal or specific groups, but the principles apply to everybody.
Exactly.
involved in research.
Yes, and it's exciting. It's exciting to see this growth. Yeah.
So, can you tell us a bit more about participatory research? Now you're the director of the participatory research program at Mcgill.
Yes, so that's why I stepped down as being PI in the Kahnawake School's Diabetes Prevention Project, because in 2006 I had the opportunity to open this new center at Mcgill, participatory research at Mcgill. So our vision is to encourage adoption of this approach to research when it's applicable, and to build capacity amongst faculty, postgraduates, undergraduates at Mcgill in this research approach. So instead of researchers making all the decisions in a research project, which has been the conventional way of undertaking research, this is researchers working in partnership with the people affected by the issue being studied, or the people who need to use the results, so policymakers, for instance. So the teams can be researchers, with patients, patients' organizations, health professionals, health professional organizations. It really depends on what the project is, what the topic of the project is, how much time you have, and how big an advisory board you want to be working with.
Okay.
So it's rich. I mean, the philosophy is that everybody has expertise. Whatever that expertise is going to be different from everybody else's. If you're doing a patient satisfaction study of services at, for instance, a family medicine teaching clinic, the patients have the expertise of what it's like to be a patient. The receptionists have the expertise of what it's like to be the receptionist. The physicians, the nurses, the residents, I mean, their expertise is maybe more obvious. But it's really important to remember that just everybody has their expertise coming from their own background.
I was just talking to somebody the other day about quantitative versus qualitative research, and listening to the person who has the problem or the patient.
Yes.
How important that is.
Yes, and so we talk about participatory research as being an approach, and then the method, is your qualitative, is your quantitative, or your mixed methods. Depending on, what the topic is and what sort of information you want.
So I would think participatory research could be used in many, many situations.
Yes, absolutely. Yeah, absolutely. It's a question of the researcher, though, needs to give up control.
Okay.
Needs to start sharing control and shared decision making throughout the project. And in an ideal participatory research project, everybody would be involved in shaping the research question, maybe or maybe not in collecting the data, maybe or maybe not in analyzing the data, absolutely interpreting the early data analysis, because everyone again is going to see it, in a different way, and absolutely in disseminating the data, making decisions about what's the importance of this data, who should know about it, and who should be taking the data out. Because there's lots of evidence to show that people learn best from their peers.
I see. So you, for example, would share the data and your findings and what you've learned with your peers.
Right.
People who are the patients would be talking to their peers,
yes.
for example.
Yes. Mm-hmm. It doesn't have to be exclusively that way, and quite often, we go out in pairs. We know the sort of, different members of the team will go out together. Sometimes the researcher will go out with different members of the team in case there's, detailed questions about, data analysis or something like that, or accuracy of scientific data. But absolutely, especially people like policymakers. Policymakers really listen to each other much. And, policymakers use different language.
Yes.
And so they just relate better to each other. So probably much better to have your policymaker on your team, go out and try and influence a major funding agency or a major, government agency than have a researcher attempt to do that. Oh, these are generalizations, right?
It sounds like it makes sense.
Yeah. Yeah.
I've heard you talk before about the challenges of participatory research. It sounds to me like it takes some special kind of thinking, thought processes, of this special sort of approach to making it all work properly.
The biggest challenge is the time.
Okay.
The time it takes. Because you need a lot of meetings. The time to keep everybody on the same page, the time to make sure that everybody feels that their opinion is listened to respectfully, the time to come to consensus. My experience is that, at time that can all seem quite long, and then there are also other times when community is absolutely racing forward, and as researchers, you're racing to, to keep up.
I see.
Yeah, so sure there are challenges, you know, in the shared decision making and different points of view, and then in these longer projects, you know, people leave, new people come in, and you have to take the time, you know, sort of to go back to the beginning a little bit and get everyone up to speed. So, yeah.
Tell me, so in the process of your research, what was the most rewarding bit of research or project you worked on?
Well, I can think of a couple of examples.
Sure.
So one is inside this project in Ganawagi is the capacity building that has occurred. And the formal academic capacity building, so out of a community of 8,500 people, because of this project, somebody from the community has her PhD and is now starting her postdoc. Two people have master's degrees. One of those people with a master's degree is just starting her PhD this year. She's so excited about it. She's here at Mcgill and she's so excited. And there's another person from the community starting her master's this year as well. So this is the future of that project. And it's wonderful to see that growth. And these are all, they all happen to be women. They're all women from the community who are very comfortable with Western science. But they're very comfortable with tradition and Aboriginal tradition. And they're able to combine the two. And it's very powerful. It's very powerful.
The community, their home community, and work like that.
Yes, they may not be there full time. I mean, that's you know, it's hard to expect Aboriginal people. They should, you know, always go back and, you know, be in their own community. I mean, wherever they go, if they come back and stay in the project, it'll be wonderful. If they move in and out, it'll work well. And if they choose to work somewhere else, you know, they're going to influence other people in another way. So it's
all powerful.
It's all powerful. It's all powerful potential. The other aspect which I find incredibly rewarding is watching other teams start up.
Okay.
So these are teams at Mcgill. But the team I think is the most powerful is Ruth Martin's team. Participatory research with women who were in prison.
Right.
It's now evolved into women who've left prison. And it's just extraordinary to watch the growth and the development of everybody on that team. Oh, it's very powerful. It's very moving.
Now,
You've heard them?
The women she's worked with travel with her and
Yes.
present.
Yes. It's very powerful.
Very good.
Yeah.
Looking back over your career, is there anything you would have done differently?
Oh yes. I would have got my master's in public health.
Really?
Yes. Because I never had formal research training.
You didn't. Wow.
I started to get my diploma in epidemiology at Mcgill, and didn't finish. So all of my research I've learnt through reading, through teaching myself, through going to sessions, but it's not what I recommend to other people. And I strongly recommend that anyone who wants to be involved with family medicine research find a way at some point in their career of stopping the family medicine and taking the time out, you know, for a formal research qualification.
Well, I guess there wasn't any training for the first generation or two, was there?
No. You're absolutely right.
So,
but that's the strength of family medicine research today, is that so many people are so well trained. And the quality of research is very high these days. That's exciting to see as well.
So that's thanks to people like you who taught yourselves and then taught others.
Yes, and I think it's also this. Well, it's also the thanks to people who went ahead of me. I mean, people like Walter Rosser, and I mean the greats, who at least a decade or maybe 2 decades ahead of me. And the general acceptance that family medicine is an academic discipline today.
Right.
So huge changes, and it's exciting to see. And now there's Canadian Institutes of Health Research are putting significant funding, as we heard yesterday, into primary healthcare research. And we're going to start to be able to work in large national teams and address concerns that are really prevalent in the country.
Okay. What else? Now, the discipline is moving forward. It's a good time for this discipline. What do we need for the future? How do we ensure we maintain that forward momentum?
Well, I think there are internal issues, and I think there are many external issues. And the biggest challenge at a national level is the shortage of primary healthcare professionals in the country. And the pressure that everybody is under as a clinician or a primary healthcare professional to take care of their patients in an aging population, a more complex medical environment. And how can people who are needing to spend time in the office and meet the needs of their patients, find the time to do research as well. Inside family medicine research, I think there's a need for our own training program. So Mcgill, for instance, has just started a master's program in family medicine. We're now in the 2nd year. We're going to develop a PhD in family medicine as well, so that people can, really choose to take this research path. And also the need for clinician scientists and the need for funding for those people as well.
How do we convince the people who have the money to share it with family medicine research and fund your projects?
To continue to produce high-class research. That people, is the same struggle as we've had in family medicine, to help the specialties to recognize that we have our own strengths and our own expertise, and that we bring very important questions to the table. There's that wonderful work that originated with Kerr White in the US and was revisited by Larry Green in an article in the New England Journal of Medicine in 2001. And it showed that for every 1,000 people in the community, about half go to see a physician in a month, and about 1% end up in a tertiary care hospital. So much research in medicine is done on 1% of the population who are hospitalized. And what we need is to increase the research at a population level.
For the other 99%.
Absolutely. Yeah, absolutely. We can improve the health of the people and the population. It's going to do more to improve the health of the population of the country than in addition to the specialized research that goes on.
Preventive medicine.
Yes.
And
yes.
Caring for situations and
yes.
conditions that happen in the family practice.
Yes, absolutely. And helping family physicians to make easier decisions in complex situations.
Okay. What are the personal qualities? What advice would you give to somebody who's thinking of going into a career in family medicine? You've talked about the schooling. What would you tell somebody how, from a personal point of view, what do you have to be prepared for, and what do you have to?
No, well, I think it's important for people to know how rewarding it can be. That it's fun to be able to take care of different age groups and different conditions. It's fun to take care of families and extended families. It's fun to work in a team with other health professionals. And that don't be daunted by feeling that you have to know so much about everything, because you can't. And that most of us in family medicine end up with our own interests. And so for me, a lot of my patients were female, and a lot of them had diabetes, not exclusively, but those were sort of the areas that I knew the most, and was happiest and felt most confident taking care of patients. What was your other question?
Personal qualities.
The personal qualities?
Somebody going into the profession.
I think people choose their own professions. I think that if they have a chance, though, to see family physicians, meet family physicians early in their medical careers. So if family physicians are involved with first and second year teaching in medical school, that students have an opportunity to meet a range of family physicians and see their qualities and see their capabilities, and hear from those who are involved with research what sort of research they do and how excited they are. And they can come to conferences like this and they can see the range of topics, and I think people make their own choices.
Okay. The question, is there a question you'd like to see explored in Canadian family medicine research?
Oh, such a big question. Well, there are so many questions. I mean, there are so many questions. I mean, there are there's so many questions about how do you amalgamate different guidelines that have been developed for one disease for an individual who has many diseases. There's all the work, so much work that has been done between physician-patient interactions. There's always more to be done there. Better understanding of why people choose to maybe self-medicate. And I think the important thing is, and the advantage of family medicine research, many family medicine researchers, they continue to see patients. And therefore the questions will arise out of the practice. And these are the ones that are going to be extremely valuable, because you're going to be able to use the results back in the practice. Well, back in the practice, but hopefully also generalizable. They're going to be generalizable to other people's practices as well. Yeah, yeah.
If you hadn't taken the research path, what other career might you have followed?
Well, I didn't plan to take the research path. I mean, that's the interesting thing. I just really tumbled into it.
Really?
Well, I really tumbled into it based on clinical impressions, right? Trying to better understand why. I mean, my original question was, why do some people breastfeed and some people bottle feed? And try to better understand the decisions that people were making to improve that prenatal program. So it didn't really start off as, it certainly wasn't research for research's sake. It was always asking a question to make a difference in getting answers and learning new knowledge that one could incorporate into programs or practice, individual for a patient or at a population level. And then I think the diabetes research just began like that as well. We wanted to know why. We wanted to know more. We wanted to better understand more. And then, interestingly enough, the community came up with the next question. And we changed our plan. We had planned, in fact, to start a prospective study following complications of diabetes. And we were expecting to find, that smokers, had higher rates of stroke and that sort of thing. And again, hoping to take community knowledge that was relevant to the people in the community. But then when community came to us and said, oh, well, we want you to prevent this disease, that was obviously a much more important question than our own. And the interesting thing is we've just been undertaking a knowledge synthesis at Mcgill, so under the Participatory Research in Mcgill Centre, and looking at other participatory research projects. And many people have had the same experience, which again is the strength of the participatory research, that the question that the researcher has in mind at the beginning of the project may not be the right question and may either get modified or may get totally changed by the group at the table. And it's usually the group at the table, they come from community, so they know, they have this instinct of knowing what needs to happen. And so several of these long-standing projects have actually come from community questions.
That's pretty.
Can I
ask you one more question?
Sure.
You've received the Order of Canada.
Yes.
How did that make you feel?
So I received it for contributions to Aboriginal health. So I started in Kahnawake, as I told you, in 1970. I was awarded the Order of Canada 3 or 4 years ago, so I had been there for about 35 years. And through the work there, through the project we've talked about, but also I had become involved at a national level in Aboriginal health. So I had spent a lot of time in the early years lobbying for improved health services and improved program and increased program dollars for Aboriginal peoples, especially in diabetes, because the prevalence of diabetes in Aboriginal people is actually 3 to 5 times the national average. And so because of all of that work, some people decided to put my name forward. So it was I was very moved, and of course going up to Rideau Hall and receiving it was an incredible experience. So my father was still alive. He was then 91, so he came over from the UK. My children were there, and it was just very, very special. Thank you.